Okay, good morning and Assalamualaikum to all students. The title of the lecture today will be on liver functions and metabolism. My name is Yasmin Anum Yusof. I'm from the Department of Biochemistry, Medical School. And the references to today's lecture, you can refer to two books of most important. Okay, one is Basic Medical Biochemistry by Smith and Marks, and the second one is Medical Biochemistry by Baines and Dominizek. Right. The objectives of today's lecture is just to look briefly at the structure and anatomy of the liver and the liver functions with emphasis on bilirubin metabolism and jaundice. Okay, we will start with a case, and I usually like to start my lecture on a case. Okay, now this is about a 35-year-old woman complained of malaise. Malaise means feeling tired and having pain at upper abdominal area for 4 weeks. She noticed her urine to be dark in color 6 days ago and yellowish discoloration of eyes 3 days ago. The following are her laboratory results for liver function tests and serology. Right, the total protein is 71 gram per liter, the normal is 60 to 80, albumin is 42, normal is 30 to 50 gram per liter. ALP stands for alkaline phosphatase, which is 180 unit per liter, and the normal should be 30 to 120. The alanine aminotransferase is 2090 unit per liter, normal should be less than 40. And the aspartate aminotransferase is 1788 unit per liter, and the normal range should be less than 35, with bilirubin 126 micromole per liter, which normal should be less than 20 micromole per liter. The urine bilirubin is positive, urobilinogen is positive, and for the serology test, hepatitis B is found to be positive. Now you are supposed to interpret the results, and I expect at the end of the lecture you can interpret the results of this case. Right, let's go to a little bit about the anatomy of the liver. Okay, now the liver lies in the upper right sides of your abdomen, okay, which is below the upper right side of the abdomen, okay, and below the diaphragm, as you can see here. See, this is the esophagus, below the diaphragm, and you see your liver. Now it's the largest internal organ, weighing about 1.3 to 1.8 kilogram, and it is the only organ that will regenerate if you resect it. And this you can see if you're working in the laboratory with rats or mice. If you resect a little bit of one of the lobe of the liver, a few weeks later you see the liver regenerate. So it's really amazing, yeah, to see this happening. Right. If we zoom into the one lobe of the liver, okay, we zoom into one lobe of the liver, we can see a lot of lobules. If you can only see this through microscope, you cannot just see it with the naked eye. If you were to look it through the microscope or the electron micrograph, you will see a lot of liver lobules. Okay, it's a shape in a hexagon shape. So this is the one that I'm pointing out. This is a lot of liver lobules. Okay, and what we are going to do now, we are going to zoom into this liver lobule, and of course, since this is liver, and you will see a lot of liver cells which are called hepatocytes, okay, in the lobule. You will see in a short while. So this is the structure of your liver, and then you can see the bile duct, okay, the common bile duct that will lead to the intestine. And there's of course gallbladder within the liver lobes. Right, let's zoom in further. Okay, we are now looking at one of the lobule that I showed just now. If we were to look at one of the lobule and at one of the corner, okay, there are 6 corners. If you remember, it's a hexagon. There are 6 corners. Now, every corner, there is this triad. Okay, we call it portal triad. You have the portal vein, the liver artery, and the bile duct. Okay, and this is very unique structure of each lobule. And inside the lobule, you see an array of hepatocytes. Okay, these are all hepatocytes. This is liver cells. Now, in between the rows of the hepatocytes, you will see sinusoid. We call this space sinusoids. Okay, and at the sinusoids, you see like little creepy cell, which we call KUPPFER cells. The KUPPFER cells, okay, here they are like macrophages. Okay, so meaning they will just engulf any foreign materials. Right, so this is the venous Okay, the artery going in, and this is the central vein. Okay, so this is the central vein. So the venous going and it's empty into the central vein. Right. So now let's look at the next slide. If we were to look at the photomicrograph and you look under microscope and you stain it with the hematoxylin and eosin, this is what I meant for this portal triad. Okay, you see the bile duct just now, the artery and the vein. So this is like at the corner, but of course you are not able to see the hexagon here, but this is what you will see when you do when you have a hematoxylin eosin slide of the liver cells, okay, of liver tissue. Now let's look at the what really happened after you have meals. Yeah, for example, the blood. Yeah, after you have meals full of nutrients, and it will leave via the portal vein. Okay, and it will enter, because you know most of the metabolism occur in the liver, right? Your carbohydrate metabolism, lipid metabolism. So now your blood now, which is full of nutrients, okay, will enter via the portal vein, and it will, remember I said about the sinusoidal space, that is where it is going to go first. And remember, you have got this like guard cells, which is called KUPPFER cells. Okay, the KUPPFER cells there, which are also the endothelial cells, which line the sinusoidal space. They will engulf any foreign materials, bacteria, virus, okay, any toxic compound. So they will eliminate it, and then there will be an exchange of nutrients and excretory materials in the blood system in the hepatocyte. So now it's going into the hepatocytes where the metabolism will occur. And then the end of the metabolites after the metabolism will empty through the central vein. So I hope you get a little bit of the picture of the anatomy, yeah, of what happened in the liver cells after a meal. Okay. Now let's zoom into the hepatocyte cells. So what you are looking here is like 3 hepatocytes. Okay. So this is the nucleus, and then you can see what I would like to point out to you is actually the little holes that is in between, or the gap that is in between each hepatocyte. Okay, right. I will explain a little bit later. Now, this is the KUPPFER cells as you are looking from a different angle now. Okay, and this is your hepatocytes, and this is called the bile canaliculi. Okay, this gap is actually very important. Once your bile is formed in the liver cells, and it will go through the bile canaliculi into the biliary system. Okay, and the same pathway is going to happen for your bilirubin. Once your bilirubin is formed, it will also go through the same pathway into the bile canaliculi, the biliary tree highway, and then the main bile duct, and then it will go to the intestine. This is the sinusoidal space. This is the endothelial cell. Okay, and now we're going to look at the biliary system, the one that I just showed to you, which was like a different angle. And now we will look back at the organ, which is the liver, the gallbladder. Okay, your liver has got a few lobes here, the left, okay, and the right. And then you've got the hepatic duct. Yeah, remember I was talking about the canaliculi empty into the biliary tree. So it goes into the left hepatic duct, right hepatic duct, and then it will empty into the common hepatic duct. Okay, and there's a gallbladder there. It will enter into the duodenum first, and then it will go into the intestine, and this is your stomach, okay, and your pancreas. Okay, now we have finished about the anatomy of the liver. We are now going to go into the functions of the liver, right? What are we going to emphasize? We'll just look overall first on the function of the liver. Okay, main function of the liver is detoxification of drugs. Okay, whatever drugs that you take, like you know, the one that you take for treatment, or any foreign compound that's found in your food. Yeah, there's a lot of foreign compound that's found inside the food, the preservatives and so on, colors, okay, coloring agents, and alcohol. They will be detoxified by your liver. That's one of the functions. The next function is for the synthesis of your proteins that are found in the plasma. For example, albumin, ceruloplasmin, C-reactive protein. Okay, so there's about 20 or more of protein plasma. Okay, your blood clotting factors. Okay, what is also being synthesized by your liver, right? And then the metabolism of bilirubin. That's what we are going to emphasize today. Okay, what do you mean by metabolism of bilirubin? Steroids, okay, the steroid hormones found in your body, they are being catabolized by your liver. How is cholesterol synthesized? By your liver. The synthesis of blood clotting factors, as I've mentioned just now. The metabolism of most of your macromolecules, carbohydrate, protein, lipid, occurs in the liver. Okay, the synthesis of bile acids from cholesterol. And liver is also the site of the storage of vitamins and minerals. And as you know, the catabolism of amino acids or protein, the final product is urea. And they need to be excreted. And liver is the main function that will excrete the final product of the catabolism of protein. Right. So that's so much about the function of the liver. Now, a little bit about catabolism of the steroid hormones. How does the liver do it? Right? Now, your steroid hormone actually is being synthesized from cholesterol. Okay, so this is the cholesterol, and of course, the main structure, the ring structure here is the basis for the formation of the hormone. For example, here is cortisol. Okay, right, and usually steroid hormones are synthesized in the kidney, yeah, in the adrenal glands. Although it is synthesized in the kidney, but the degradation occurs in the liver. Now, how does that happen? So there is a two main process, reduction and hydroxylation. Reduction is just to ensure all the double bonds that you can see here is being reduced. Then you hydroxylate it with a lot of hydroxyl groups so that you make it water soluble and they can be excreted into your urine. So those are the two main things that will happen to most of the hormones when they are being catabolized. For example, let's take cortisol. Yeah, it is a glucocorticoid. There's double bond here, so it will be reduced. Okay, and the hydroxyl group will be added up, and it becomes now tetrahydroxycortisol. So there are 4 hydroxyl groups that are being added. So it makes it water soluble, right? Now, another example is your estrogen, the female steroid hormone. And it will be converted to estrone and estriol once the hydroxyl groups are being added. Then it will be excreted into the urine. Progesterone, okay, it will be reduced to pregnanediol and then hydroxylated pregnantriol. The androgen male sex hormone to androsterone and ethiocholinone. Now, all these metabolites are conjugated with glucuronic acid to make it more water soluble. Okay, we will look later at what I meant by glucuronic acid when we are discussing about the metabolism of bilirubin. They will be excreted into the kidney. Once it is combined with the glucuronic acid, the metabolites will be more water soluble. Right, 70 to 80% of hormone metabolites are excreted in the urine, and thus they can be used as a form of diagnosis for certain endocrine disorders. Yeah? Right. Now, what happens if, for example, you get your liver, there's problem with the liver, there's chronic liver disease, for example, like liver cirrhosis, yeah, chronic hepatitis. So all the functions of the liver that I described just now may be affected. Not all, maybe some of them will be affected. Now, in chronic liver disease like liver cirrhosis, for example, you can see in male enlargement of the breast due to failure to degrade the steroid hormones. Yeah, for example, male has got some little bit of female steroid hormones, not much, but they will be excreted by the way of the catabolism of the steroid hormones. But when there's something wrong with the liver, it cannot catabolize, so that small amount of female steroid hormones will be accumulated in the body. So where will it go? It will go to the breast. So this enlargement of breast in male we call gynecomastia. So that's one of the symptoms that you can see for someone, an individual who has liver cirrhosis or other chronic liver disease. Now, other functions of liver, which is storage and metabolisms of vitamins and minerals. Yeah? For example, vitamin A, the retinol is transported by a retinol binding protein in the blood and then being stored in the liver. Okay? Vitamin D, which is synthesized right from your skin and then activated in the liver, okay? And then also in the kidney, which will finally be formed into calcitriol. Okay? In the liver, it will be calcitriol. Vitamin E is also being stored in the liver, okay, in the tocopherol state or in the chylomicron remnants in the form of ApoE, right? And vitamin K cycle, which is important during the synthesis of your clotting factors, also happen in the liver. Okay, so you can see all the lipid soluble vitamins A, D, E, K. Okay, the main metabolism, its cycle, and is being stored in the liver. Okay, vitamin B12 also, in addition to the lipid soluble vitamin, is also being stored in the liver. So when there is advanced liver failure, what will happen? All that functions where it is storing the vitamins or the metabolism will be affected. For example, it will cause night blindness. You do not have enough vitamin A. It will cause ricket and osteomalacia when you do not have enough vitamin D. And it will cause pernicious anemia if there is lacking in vitamin B12 because your liver cannot store the B12. Right. Let's now have a look at storage of iron. Liver is a very good source of iron. Most of you know that. Now, how is iron being kept in the liver? In what form? It is being kept in the form of ferritin. This is one of the plasma protein that is being synthesized by your liver, and it will bind to the iron and kept in the liver. Okay. Other form will be in the form of hemosiderin, and that will be kept in the KUPPFER cells, which I have shown to you earlier. Now, how is iron being transported right from your intestine to wherever it is being needed? Yeah, for example, you know iron is important for the synthesis of red blood cells and so on. So it will be transferred by a plasma protein called transferrin. Okay, then it goes into the liver, stored in the form of ferritin. Now, there's one disease which is called hemochromatosis. Okay, this is actually an inherited metabolic disorder whereby your body absorbs more iron than it really needs. You know, you only need a certain amount of iron because your iron does not get excreted so much. It's being reutilized. But if you absorb more than what is needed, it will go somewhere. So where does it go? It will accumulate into the liver. Okay, and with time and with a long duration, it will harden your liver. Okay, it will cause hemochromatosis. So that's a form of liver disease, and in the usually towards the end stage, you'll become cirrhosis, okay, fibrous and cirrhosis. Right. Now let's look at storage of copper. As we know, copper is also being stored in the liver, okay, and copper is being transported by a protein called ceruloplasmin. Copper is very important as part of the coenzyme, as you know. So sometimes when there's a liver failure, the synthesis of ceruloplasmin, which transport your copper, is being reduced. So as a result, again, your copper will be deposited somewhere because there is not enough transport for the copper, so it will get deposited somewhere. So where does it get deposited? In your liver, just like iron just now. So it gets deposited in the liver, causing liver cirrhosis. And this is one. If it is an inherited disorder, it is called Wilson's disease. Yeah? And where else does it go? Yeah? It will also goes to the lens of the eyes, okay, and it will damage the lens of the eyes. It will go to the kidney, it will go to the brain, okay, it will cause dementia also. But if it goes to the lens, we can see the symptoms in this patient like a greenish ring around here, surrounding the eyeball. Okay, you can see this. This is it's not as a cosmetic like what you would think, but this is more of a symptom for people who are having problem with the copper metabolism. And this is called Kaiser-Fleischer ring. The excess copper will overflow from the liver, and if it goes to the brain, it will cause psychiatric disorder. Okay, and into the eyes, this is what you will see. Right. So we have finished all about the function of the liver in terms of its storage for the vitamins and minerals. Right. Now, I'm going to emphasize on the metabolism of bilirubin and its excretion. Okay? And after that, we look at the types of jaundice. Right. Now, where does the red blood cells get catabolized? Okay, as you know, your red blood cells will be hemolyzed every 120 days. And this usually happens at the reticuloendothelial cells, like in the spleen, in the bone marrow, as well as in the liver, in the KUPPFER cells. Okay, so every 120 days, your red blood cells get catabolized, and the end product will be bilirubin. Okay, and from bilirubin, you've got an enzyme which is called bilirubin reductase, which will convert it to bilirubin. So you've got red blood cells, yeah, which is inside the red blood cell, got a lot of hemoglobin, millions and millions of hemoglobin that carries oxygen. So the heme plus globin, right? So when it gets degraded, the globin, which is the protein part, will get, will be unbound from the hemoglobin, and that will be catabolized into amino acid, and we go into the amino acid pool. But what about the porphyrin, the heme that is in the center of the red blood cells? That is the one, okay, that will be degraded. The iron portion will come out. Remember, iron will be in the center of your porphyrin, so the iron will be reutilized. But the porphyrin ring now, that is the one that is going to be degraded into bilirubin. So before bilirubin, it will be biliverdin first. So this is several steps that I have already summarized, okay, into the final step. So you can refer to the textbook to see how catabolism of hemoglobin occur. So right, this bilirubin, which maybe will be about 250 to 350 milligram per day, need to be excreted. Okay, because if it gets to be higher, it can cross to the blood-brain barrier, and it will cause damage to your brain cells. Right? So it needs to be excreted by your liver. Right, now bilirubin is lipid soluble. Right, so once it gets into the blood, if it is lipid soluble, your blood is 70% water. Right, it's water soluble. There's something lipid there, something needs to carry it. So the carrier is your albumin. Right? So albumin, remember, one of the plasma protein, so it will carry your bilirubin. Now albumin is also a carrier of most of your drugs that are lipid soluble. Right, so here you see that albumin will combine with the bilirubin that is lipid soluble. We call this bilirubin unconjugated bilirubin. Okay, if you see here, the bilirubin is actually pink in color as I've shown here, and albumin is about yellow. It's just for a matter of animation, okay? They are not what the color should be. Now, if we look at the next slide, the bilirubin, which is being bound with the albumin, coming into the liver cells, okay? And once it is taken up by a special enzyme, which is called ligandin, okay? This is green, which is called ligandin. Now, once it is taken up, it will be conjugated with glucuronic acid. Okay, remember I said about diglucuronide earlier for the catabolism of hormone? Right, this is where it's going to happen, in the smooth endoplasmic reticulum. Yeah? So in the smooth endoplasmic reticulum, there is an enzyme that is called UDP glucuronyl transferase. So that is going to conjugate this bilirubin with 2 molecules of glucuronic acid, and you will have now conjugated bilirubin. Why do you need to do this? It is mainly to make it water soluble, so that it can be excreted in your feces and in your urine. Yeah? So now you have bilirubin diglucuronide, or it is also known as conjugated bilirubin. You remember about the anatomy of the hepatocytes? I showed about the canaliculi. So this is where the conjugated bilirubin is going into the canaliculi between the hepatocytes, into the biliary tree, okay, right? And then it's going to the main bile duct, right? So that it will be going to go to the gallbladder. It will be stored. Some of it will be stored, yeah, but majority of it will go into the duodenum, okay, into the small intestine. Now, here the conjugated bilirubin with the action of the bacteria, yeah, which has got this bacteria beta-glucuronidase, which will convert it to urobilinogen. Okay, so this is a pigment. Okay, it's colored almost like yellowish brown. Now, this urobilinogen will be converted to stercobilin. Stercobilinogen first, then it will be converted to stercobilin. So you see, from your conjugated bilirubin converted to urobilinogen, this happened in the intestine, okay? And then in the large intestine, it will be converted to stercobilin. And this is the pigment that will color your feces brownish, yellowish color. Okay, so that's how your bilirubin is going to be excreted. Now, stercobilin can also be, urobilinogen can also be converted to urobilin, and it also will color your feces yellowish brown. Majority of your feces actually consists of your stercobilin. So about 80% of your urobilinogen actually will be transported through portal vein, will be taken up by your at the duodenum area, okay, at the ileum area, it will be reabsorbed into the portal vein, and then it will go back into the liver. So this is called enterohepatic circulation. Okay, so this urobilinogen will be circulated back into the liver, and the whole process is going to be repeated until you get again urobilinogen. Majority of this urobilinogen will be excreted into your kidney. So what you see in your kidney now is actually urobilin. The urobilinogen is converted to urobilin. So your urine color, which is yellow, is actually due to urobilin. So again, there is a end product of your excretion of your bilirubin, as you see from the beginning just now, from the catabolism of the red blood cells right until the end, where they are being excreted in the form of urobilin in the urine and stercobilin in the feces. Okay, so that is the summary of the excretion of your bilirubin. Okay, so this is just to show you how bilirubin, okay, this is how the structure of bilirubin is like a polymer, yeah, and it will combine with two molecules of glucuronic acid and you will have bilirubin diglucuronide. Now you can, okay, the enzyme is UDP glucuronyl transferase. Right, these are some of the websites that you can refer to and it's very useful. If you can access the iFolio, go to my website. I have already downloaded a few websites where bilirubin is made simple for you to really go over the slides, the YouTube presentation, okay, animation. Now the last address of the website that you can go into, which is also in the YouTube, is actually being prepared by medical students. They did themselves. Okay, they draw and they talk about the bilirubin made simple. So you can have a look at all those websites. So this is a project of a medical student 2 years ago. Now, let's look at next the jaundice and its causes. Okay, so we have seen a little bit about the anatomy of the liver. We have seen about the functions of the liver and we have emphasized on the bilirubin metabolism just a few seconds ago. And now we are going to look at jaundice and its causes. What is jaundice? Okay, what do you mean by jaundice? Okay, jaundice is yellowish discoloration of the skin, okay, and the sclera of your eyes. Why? Okay, most probably it can be due to bilirubin. Why did I say most probably? Okay, people who are on a diet freak with high amount of carrot can also produce the same thing. You can see the discoloration, but that is due to the pigment the pigment that is found in the carrot, and we call that sometimes carotenemia. But in this case, we are only focusing on jaundice due to bilirubin. Okay, so now when can you see this yellowish discoloration of the eyes and the skin? It is only when your bilirubin gets to be more than 20 micromole per liter. This is normal if it is less, but if it is more, about 40 micromole per liter, then you started seeing a little bit of the jaundice in the skin, in the eyes. Not so much yet. When it reaches about 80, 100 micromole per liter, then you can see the patient is yellowish in color. Okay, right. In your blood, usually a normal amount of conjugated bilirubin is less than unconjugated. Remember about unconjugated just now when I say the red blood cells get catabolized, final product biliverdin, bilirubin, that bilirubin is unconjugated, you've got about 80% which is unconjugated or lipid soluble. And the conjugated is about 20%. So if you were to look at this 20 micromole per liter, 5 micromole will be conjugated, 15 micromole will be unconjugated bilirubin. Okay? Right. Now, when you want to look at jaundice, you have to know whether is it due to the liver or non-liver origin. Why do I say non-liver origin? Okay, non-liver origin means your red blood cells, remember I said just now, it catabolizes every 120 days. But sometimes when you've got disease like sickle cell anemia, thalassemia, where the red blood cell disorder, they get catabolized earlier than expected. Earlier than 120 days. So red blood cells catabolize a lot. As a result, what will be high? It will be bilirubin. So that bilirubin that is high is nothing to do with the liver disorder. It is mainly due to the red blood cell disorder. Okay, it's something to do with the, it's called hemoglobinopathies. Okay, so you need to know, is it due to liver or non-liver origin? Right. Now, if it is due to the liver, you can divide it into few categories. One of it, okay, if it is non-liver, we call it hemolysis or pre-hepatic jaundice. I mean, it happens before it enters the liver. So we call it pre-hepatic jaundice. So this is the one I've just explained to you. Hemolysis, premature destruction of RBC due to intrinsic inherited defects, okay, or because of acquired intravascular abnormalities. Sometimes the vascular abnormalities can also cause red blood cells lyse earlier than normal. The unconjugated bilirubin is increased in this case. As you know, when red blood cells lyse, what is the first bilirubin, the type of bilirubin that will be high will be unconjugated. So in pre-hepatic jaundice, unconjugated bilirubin will be high if you measure in the blood of the patient. Now, as a result, if you have more unconjugated, it will be metabolized in the liver, and your urobilinogen will also be high. Remember I said about urobilinogen will be absorbed through the enterohepatic circulation. It will go to the kidney and then found in the urine. So urobilinogen high, unconjugated bilirubin will be high. Now let's look at other causes. Failure of conjugation mechanism. Remember, the conjugation mechanism is the one that happened in the liver. The unconjugated will become conjugated. So we call this conjugation mechanism. The enzyme is called the UDP, glucuronidase. Sometimes this conjugation mechanism is not happening at full force. When? Especially when you do not have enough of this enzyme. So some babies who are born, okay, they will have this inherited disease which we call Crigler-Najjar syndrome, meaning their enzymes is found to be deficient. Okay, when babies who are born, in this case, they will not survive long because the bilirubin gets accumulated and it will cross into the blood-brain barrier. Okay. Sometimes it can be due to drug. Drug can induce this to occur also. Okay, for your red blood cells, either to lyse more than necessary, or it can even cause damage to the liver. And the liver is doing a lot of work trying to conjugate this drug. Damaged liver cells, for example, in chronic infection by virus or toxin. Okay, toxin can be found in some food, yeah, or even in drugs. And then, what happened in this case is that the unconjugated bilirubin will be high. Okay, so because it cannot conjugate. Okay, so if I were to go back, why did I say high? Because you do not have enough of the enzyme. You have unconjugated coming, but it cannot go to conjugated bilirubin. Therefore, what will be backlogged? It will be your unconjugated bilirubin. Okay, so the unconjugated bilirubin will be high in this case. Now, let's look at obstructive jaundice. What do you mean by obstructive jaundice? Okay, it's also known as cholestatic jaundice. Now, what it means, cholestatic means the bile flow or the bilirubin flow in the highway. Remember I was talking about the biliary trees and all that? Is stopped. Why? Why is there a stopped flow of the bilirubin? Could be a gallstone. Okay, a gallstone that forms as a result of your abnormal movement of your gallbladder. Okay, cholesterol is very high or bile acid is very low. Okay, that will be another lecture. Right, so the gallstone that is formed there will come out from your gallbladder. It gets dislodged in your biliary tree. Okay, so it gets dislodged. Remember, I was showing you the main bile duct. So it's like a pipe. You've got a stone, it coming in there, and it got blocked there. Okay, so then your bile flow is stopped. Your bilirubin flow is stopped. The other reason is when you have cancer. Remember, I was showing the structure of the pancreas. If you look back at the anatomy, look back at the pancreas there, it is just right to the bile duct. So this is pancreas, this is your bile duct. If there is cancer at the head of the pancreas, it will squeeze your bile duct. Okay? So when you squeeze the bile duct, there is also an obstruction of the bile flow. Other reason, drug induced. Okay? Hepatitis. Hepatitis meaning when you have viral hepatitis, all your liver cells that I've showed you just now in the lobes inflame. So when liver cells get inflamed, it will swell. Yeah? So inflammation usually goes on with swelling. So when all the liver cells swell, it will squeeze all your biliary trees and as well as your biliary duct. So again, it looks like there's a blockage. Okay? So all this will cause increased bilirubin in the blood. So mainly conjugated bilirubin. Why? Because the process of conjugation, no problem. Unconjugated has already been converted to conjugated. But the problem is the conjugated now going to the canaliculi and wanted to go to the intestine, but it cannot go. So that is the reason why the conjugated bilirubin now will be high. It cannot go flow. So where will the conjugated bilirubin go? It accumulates. It will regurgitate. It will regurgitate back, or it will flow back into the bloodstream. So in your blood, if you were to take, you will see increased conjugated bilirubin. Okay. Now anything that's high in the blood, there's a renal threshold. So your kidney will filter off anything that's higher than the renal threshold. So in your urine now, you will see conjugated bilirubin. Now once conjugated bilirubin goes into the urine, it gets auto-oxidized and become dark colored. So your urine, the patient will notice the urine looks like tea-colored urine. So the reason is because the conjugated bilirubin is found in the urine. Now, besides that, in obstruction, there's one enzyme that's called alkaline phosphatase. Alkaline phosphatase is found at the lining of the biliary tract. Yeah, biliary tract, bile duct, that's where your alkaline phosphatase is found. At the liver caniculi, okay? So when there is obstruction, the enzyme is being stimulated to synthesize more. So when you have more alkaline phosphatase being synthesized, it will leak out into the blood. So if you were to take the blood of this patient, you will see alkaline phosphatase very high. This is unique to obstructive jaundice. Okay, the alkaline phosphatase is high in cholestatic type of jaundice. It's more than 5 times than normal. Other enzyme that you can also measure is gamma glutamate transpeptidase. So I'm not going to go into that so detail, but that is actually just to show other enzyme that is also high, and they are found at the same site as alkaline phosphatase. The other thing that you will notice is that this patient will see their feces to be pale in color. Okay? Pale in color, why? Remember I said just now, bilirubin get excreted in the form of stercobilin in the feces. It makes the color yellowish brown. But now, do you have stercobilin being formed? So there's no stercobilin being formed because there is a stoppage in the blockage in the highway. So no formation of stercobilin. The bilirubin, that is the conjugated form, cannot come through to the intestine. So no formation of stercobilin, therefore no formation of colored feces. So in the end, your feces become pale color. So there's also absence of urobilinogen. Right. Next, what are some common features in bile duct obstruction that we just talked just now? Okay. Since there is no bile, okay, when there is obstruction, not only your bilirubin, your bile is also being obstructed. The bile comes from your gallbladder. Yeah. So bile get obstructed. Now you know bile is important for the absorption and digestion of your lipid-soluble vitamins and all lipid. Okay. So vitamins A, D, E, K will be affected. Okay, the absorption. What else? The fat. There will be abnormal metabolism of your lipid because you cannot digest it. So there will be a lot of lipid, and that will make your feces, yeah, floating. Some people will see their feces floating, and it's oily because there's a lot of fats. Because the fat cannot be degraded, cannot be digested, no bile. Pale feces, we have already explained. Prolonged clotting time. Remember I said one of the functions of liver is to synthesize the clotting factors. When you have, okay, in this case, why there is a prolonged clotting time? If you remember, vitamin K is involved in the formation of 4 clotting factors. Okay, so four clotting factors. You have got about 13 clotting factors. So 4 clotting factors there needs vitamin K. So if you do not have enough vitamin K, the clotting factors cannot be synthesized. So if you cannot have the clotting factors synthesized, 2, 7, and 10, okay, if you don't have these clotting factors, then you cannot form, when there is bleeding, you cannot stop the bleeding. Therefore, your clotting time will be prolonged. Okay? Total bilirubin increase, you can easily explain that. The conjugated bilirubin now get increased. Okay, the ALP get increased. We have already explained why is the urine dark colored. I have already explained just now. And the urine urobilinogen is decreased. I have already explained. Okay, and on top of all this, some symptoms that you can see in the patient is like this spider nevi. Spider nevi is actually a small spider-like blood vessels that is visible in the skin of the patient. Okay. If I can, okay, the other thing is that the bile that cannot be excreted will go to the skin and it causes pruritus. This patient will try to scratch and scratch. So that's one of the symptoms you see in this patient. They scratch because of the bile that cannot be excreted. And the gallbladder get enlarged because the bile cannot flow through, so the gallbladder got enlarged. So this is actually, okay, this one is actually, now we are going to the next category of jaundice, which is called hepatitis. This is very common. Most of you have heard about it. And hepatitis A or hepatitis B, hepatitis C, okay? Now, this type of jaundice, we call it hepatocellular jaundice because it's happening on in the hepatocytes. Okay, it's due to viral infection, yeah? And it can also be due to toxin, can be due to drugs, okay? Because your liver cells, okay, get inflamed, okay, as a result of the infection or as a result of the toxin, yeah? And what will happen is that when you just imagine all the liver cells get inflamed, so two most important functions of the liver in trying to get rid of the bilirubin will be affected. One is actually the conjugation process. The other one is the transportation and excretion. So these two cannot happen. So in this case, you will see both unconjugated as well as conjugated bilirubin increase in the blood of the patient. Okay? Because both mechanisms are affected. In obstructive jaundice just now, the transportation or the excretion process is affected. Conjugation, no problem. But here, both functions are affected. Along with it, there are enzymes that you can measure, which is alanine aminotransferase. Now, these enzymes, they are found in the hepatocytes. Okay, so imagine swelling because of infection. Okay, because of inflammation, swelling, the membranes get very thin. Okay, it is not normal anymore. So these enzymes that are found in the hepatocyte will leak out. So that's why you will see the enzyme found in the blood, which is alanine aminotransferase. So it's a good marker for hepatitis. Yeah. Along with ALT, you've got also another enzyme which is called aspartate aminotransferase. They are both enzymes that are important in the transamination process of amino acids. Okay. So you will have to refer back to your metabolism of amino acids to know what transamination means. So these two enzymes are involved in the amino acid metabolism. These two enzymes are found in the hepatocyte. So when the hepatocytes get damaged, these enzymes are released into the blood. So if you measure the blood, not only the bilirubin is high, but ALT, AST will be high in hepatitis. Okay? But in obstructive jaundice just now, it is the ALP that increased, the alkaline phosphatase that increased more. The ALP only very slightly increased. Only when the swelling of the cells, the hepatocytes, will squeeze on the biliary tree. So when it squeezes on the biliary tree, it looks like there's a blockage, but very slightly. Yeah? The alkaline phosphatase also increased slightly. Right. So now, okay, so we have finished this one. So what will be high? I've already shown. Okay, this is just a repeat of the previous slide. Okay, now we are going to go to neonatal jaundice. Okay, meaning babies that are born, sometimes you see they are so yellowish in color. Why? Yeah. So the main reason why the babies, you can see, get, their skin get yellowish in color, is mainly their liver is not mature. Okay, it's immature liver. Whatever that we have described about the bilirubin metabolism now is not happening at full swing in babies because of the immature liver. Okay, so that's why we call neonatal jaundice. It's not a sickness, it's a normal thing. Okay, so usually day 2 to 4, their bilirubin is still very high. Ours should be less than 20, theirs is about 100 micromole per liter. So obviously you see yellowish in color, but at day 12 or 3rd week, yeah, or maybe 2nd week, the yellowish color of the skin should subside. Yeah? But some babies, it takes longer, like a month, you still see yellowish in color. So usually, when they are in the hospital, they will monitor and see what's the level of the bilirubin. Okay? So if it gets to be higher than 240 micromole, so they take in daily or every 2 days, 3rd week still high. Yeah? 4th week, higher than 240. So you have to perform. Yeah, before this, okay, you put the baby under the UV photo light, okay, the UV light or phototherapy. We call it phototherapy. But if it is more than that, you put under phototherapy, the bilirubin still climbing up high. You have to do you have to do blood transfusion. Otherwise, it will cross into the blood-brain barrier. So only when it is higher than 300, you will do the blood transfusion. But if it is like 170, 200, 250, they will do the phototherapy. Okay, the phototherapy actually will isomerize the bilirubin and make it water soluble. Okay, so that's how, you can read further how the phototherapy works. Right, other causes of jaundice, besides the Crigler-Najjar syndrome that I was talking a while ago, you have also Gilbey syndrome because of the ligandin that's deficient. If you remember, ligandin helps in the uptake of the bilirubin inside the liver. Durbin-Johnson syndrome, the transport, once the conjugated bilirubin is formed, not transport to go to the intestine is being affected. Same thing as Rotor syndrome. Wilson disease, I have mentioned just now, copper deficit, hemochromatosis, iron deficits, and also can be due to drugs. All these can also be presented with jaundice. Okay. Now we're going to go as a summary of the metabolism of the bilirubin, normal as well as in pathological. Okay, let's look at this animation. In a normal metabolism of bilirubin, so we see this is the unconjugated bilirubin here as a result of red blood cells catabolized, normal catabolism. The unconjugated will be entered by the ligandin, if you remember, and goes to the endoplasmic reticulum, and that's where the conjugation occurs. Okay, and then you have conjugated bilirubin, will go to the bile canaliculi, you will be excreted into the intestine, and then finally into your feces. Okay, that's normal. Right. In hemolytic jaundice, remember I was saying that this is pre-hepatic jaundice. It's happening outside the liver and outside the liver. So there's a lot of liver cells get catabolized, for example, in sickle cell anemia. So a high amount of unconjugated bilirubin, which your liver cannot cope to conjugate it. Okay, so as a result, there will be a lot of unconjugated bilirubin that is not being conjugated. The one that has been conjugated will go as normal, okay, but at a very high rate now compared to the normal. Okay, so what you will have here is that unconjugated bilirubin is higher than conjugated bilirubin if you measure in the blood. Now, what about in cases where the enzyme is deficient, the UDP glucuronidase transferase? So unconjugated goes inside the endoplasmic reticulum, but it cannot be conjugated, right? So therefore, again, your unconjugated bilirubin will be high in the blood. Okay. Now, what about obstruction? Remember, I was talking about gallstone get dislodged and then block the biliary tree. Again, it can conjugate the unconjugated bilirubin, no problem. In the endoplasmic reticulum, UDP glucuronidase transferase conjugate it, but it cannot go further, cannot go to the intestine. So it will accumulate, it will flow back into the blood. So now in the blood, you have conjugated bilirubin higher than the unconjugated bilirubin. Okay? Now, I'm very sure you can solve this case now, yeah? Which is the one that I showed earlier in the first slide. A 35-year-old woman complained of malaise. She noticed pain at the upper abdominal area, that's your liver. She noticed dark-colored urine. She noticed yellowish discoloration. Okay, and this is the lab finding. Albumin is normal, total protein is still in the normal range, but your ALP is slightly high, but very high is your ALT and your AST. So if you remember just now, when these two are very high, this is in cases of hepatitis. So it is already confirmed with hepatitis B. So this patient is having hepatitis B infection, and that's the reason why you have these enzymes being high, and you have to explain to me why they are high, as I have explained just now. How the liver cells get inflamed, swelling, leaking, and then you measure in the blood, okay? The liver cells get damaged, the ALT, AST will be leaked out into the blood, okay? Why bilirubin is high? So in this case, this is hepatic type of jaundice. Both unconjugated and conjugated bilirubin is high. Why urine bilirubin is positive? It is due to the conjugated bilirubin. And as you remember, the conjugated bilirubin in the urine will auto-oxidize with light and make it look like tea color. And urobilinogen is high because there's a high rate of bilirubin metabolism. Okay, so that's it for today. Thank you.